Good afternoon and welcome to today's webinar, Give Me Base, Section GG, Take Center Stage. We are thrilled to have you all here today, joining us from all over the country. My name is Amy and I'll be your moderator for this session. Before we get started, we'd like to go over a few housekeeping items to ensure that you all have a seamless experience throughout the webinar. So first, we want to make sure that you're aware the webinar will indeed be recorded. So if you need to step away or you'd like to revisit the presentation later, no worries, the recording will be available on demand on the QRM website. You'll also receive an email after the event with a link to the recording as well as the resources that we mentioned. We will go ahead and we'll place a link to the handouts, which is essentially the presentation, in the chat area of your Zoom, which is at the bottom of your screen. So go ahead and look for that and open that PDF if you'd like to follow along. And then throughout the presentation, we do encourage you to ask questions. So you can do so by typing your questions into the Q&A area, which is in that Zoom toolbar just left to the chat area. So we will try to field as many questions as we can at the end of the webinar if time allows. And following the webinar, if we receive a large number of questions that we can't get to, we will collect those and we'll draft a Q&A document that we can share with you later to make sure that we address all your questions. So now I would like to introduce you to your presenters. We have Mark Heider, VP of Reimbursement Strategy and Education for QRM. Mark has 30 years of experience in the skilled nursing space and a deep understanding of the challenges and intricacies facing our industry today. Mark is passionate about educating the next generation of healthcare leaders and is committed to improving patient care and operational efficiencies in the facilities we support through QRM. Next, we have Megan Essery, Director of Clinical Reimbursement for QRM. With over 15 years of experience, Megan is dedicated to post-acute care with a particular focus on reimbursement and quality. Her expertise lies in utilizing MDS data, trends, and outcomes to guide process development and education for clients throughout the country. So together, they'll be guiding you through Section GG and its growing significance in reimbursement, quality measures, and the various MDS pay for performance programs. Just to remind you, we do thank you for joining, and we believe in a collaborative format for our webinars. So please do not hesitate to list those questions. We will address those at the end of the webinar. And after that, I guess I'll hand it off to Mark.
Thank you very much. We're really happy that you're here with us. So Megan and I have been talking a lot about this topic, as have most people in our industry. There's a lot of noise around Section GG. And one of the first things I want to let you know is Section GG and Section G are not the only sections that are changing on the MDS. I'm sure you already know that. But one of the biggest change is Section GG and how that will be handled when it comes to other metrics. We will be presenting another webinar in July that will address many of the other MDS changes outside of Section G and GG, because we know those items require attention as well. But we're glad you joined us today. We're excited to talk about this. We're excited to share in the conversation because so many of you are having that conversation, and it's not going to stop for a while. And I don't think it's going to stop on October 1st. I think we're going to continue to have that discussion. We're going to do what we always do with changes. We're going to kind of recalibrate, and then we're going to try it out, and then we're going to fine tune it, and then we're going to talk about it some more. Now, one of the things I love are the blog questions with different organizations. They're helpful, they're useful. One of the things I want to continue to do is make sure that you're going to really good resources and that you're not taking the answers for granted and taking those to be the answers. Still need to continue to go to the sources. And we'll talk a little bit more about that today as well. So we've got an agenda. We're going to talk a little bit about industry updates. Then we're going to walk through Section GG changes. And there are some really good ones, expected changes and things that are good for us. We're going to talk about the new discharge measure for the SNF QRP and value-based purchase programs. We're going to talk about some of the strategies for improving our Section GG collection and scoring. And then lastly, we're going to talk about the optional state assessment, the OSA, and some of those Section G items that will continue to live for a little while. Now, a lot of you are asking, questions about the OSA and Medicaid. Great questions. Those are good questions to keep in front of you. And over the next couple months, we're really going to talk more about those things as information comes up. Let's talk a little bit about some of the industry updates. Well, first, we know that the public health emergency ended in May. So you would think at this point, it's a non-issue. Well, a bunch of things happened over the last 3 or 4 years. One is we had a lot of caregivers enter the field. We had a lot of MDS coordinators, directors of rehab enter the field during the public health emergency, and they had never functioned outside of the public health emergency. So some of those waivers that were in place were things that they didn't have to deal with, those qualifying hospital stays and some of the spells of wellness, those type of things. So as you're moving forward, I want you to take a step back and say, has my staff been trained adequately to understand what business is like outside of the public health emergency? Do they have that baseline training? When we're not seeing people in isolation, what are the rules that guide us in the PDPM case mix group establishment and validation? So let's really be sensitive that we did business differently for a long time, that people entered the field and may need some new training or retraining, and address it so that your staff feels well equipped to handle business as it should be conducted now. One of the other items that came up in April was CMS's plan to educate on the proposed changes. Now, most of us know that the proposed changes will be present in the final rule, which will be released in a month and a half, something like that. What I like is that CMS did a 2-step plan. First, it has some pre-recorded training videos released on YouTube, and those came out a couple weeks ago. And if you listen to them, they're done quite well. They walk step by step through a lot of the changes. And what they anticipated is that you would watch those in anticipation of the virtual event that happens next week on June 21st. So we did put the link for that training right there that you can copy paste, go to make sure that you're listening to that source material. Of course, CMS is the ultimate source because these are their rules, their changes, the way that they're guiding our business. So as I mentioned a few minutes ago, we're waiting for that final rule. It'll come out end of July, beginning of August, and we don't anticipate a lot of significant changes. You never know, but we don't anticipate those. What'll happen from that point, though, is that mad dash to October 1st. How do you make all those changes? How do you incorporate all this information? There are always a couple strategies at play. One is you wait till the last minute because you don't know what the changes are going to be exactly, and then you try to make those changes. In my mind, bad strategy. We know what most of the changes will be, and that's why we're presenting a step-by-step method. And in August, we will actually increase the trainings that we're doing. We hope you'll join us then. But it gives you time to really absorb what the proposed changes are, see them come to life in the final rule, give yourself time to change your processes and understand how it impacts your business. Now, we know with the REI, there were quite a few changes. Now, we're going to give you an overview of some of these changes. Some of the examples are going to be very specific. Some are going to be less specific. But we always encourage you to go to the REI manual and review it, especially those sections that you're responsible for. We know that the IDT all contribute to the MDS process. You don't want to take somebody else's word for what happened. And The easy thing about the REI manual is the red text. They're telling you what's been changed. It couldn't be a whole lot easier to identify the changes. Now, incorporating those changes, learning the changes, that's a different animal, but at least we know what the changes are. A few of the things that CMS focused on with these changes was language to be more gender neutral. So you'll see a lot of the language change to them and their, those things that we're accustomed to. We know they're coming and really help people feel more comfortable in those gender designations or lack of gender designations. They've added and deleted quite a few items. And one of the best items or best features of the REI manual are those coding tips. And they went in and made quite a few changes on the coding tips. And the reason they're such a great feature is when you have scenarios and you walk through those scenarios and CMS is telling you, here's what we think you should do. Well, we know that our Max and our other reviewers are going to take that information and use it. And so we need to read through those coding tips as well as the examples. They edited some of those examples as well. Again, coding tips and examples, very, very informative, and they really help to walk through scenarios. And that's one of the best ways of learning is walk through the scenarios of a lot of those MDS item sets. So I know I pulled these right from our last webinar. I'm passionate. No rules of thumb. No playing off the sheet music. Don't make up your own rules. Don't listen to those people who said, I've been doing this for 35 years. I know all the rules. This is how I've always done it. That doesn't work because the rules change every single year. And I found that people who want to be those sources and they don't encourage you to go to the actual source usually are off a little bit, and you can't afford to be off. This is real important information. So it's the internet-based books, catalogs, the resources that CMS uses that you need to really go to. I put the Federal Register up here. Now, when I talk about sources, there's sources and resources. CMS is the source, so you can go to the Medicare policy, benefit policy manual, those type booklets and manuals. The REI is the huge one for us. But some of our professional organizations put out some really good information. American Healthcare, APAC, and some of those, Advion. There's good information there, and they're usually right on. But one of the things they'll tell you is go to the source. Don't rely on them. And even providing this training, we're telling you, this is based on the REI. This is based on the final rule. But it's in your best interest to go and read those parts that apply to you as well. And then a couple of those programs that are impacted, we have the quality measures overall. We're always worried about our quality measures, but more specifically, we're usually talking about those that are related to the value-based purchase program and the SNF QRP and our 5-star. And we know that all those manuals live on the CMS's site, and you really should go look at the user manuals for those as well. Some of the questions we can't necessarily answer haven't been published yet. You know, how are these changes going to impact my quality measures? How are we going to do this and that? It's very difficult. So today, we're going to start right off with a poll question.
All right, so who currently, we want to know because we're, nosy, who currently collects your Section GG info? Is it the admitting nurse? You get them all from therapy? Our MDS nurse? Or I'm just really not sure.
It looks like we're going back and forth, getting a lot of responses. This is good. Love to see those numbers going up and up and up. And if therapy is neck and neck with the MDS nurse, this is interesting. Like watching a horse race.
Right.
I'm calling it right here. Let's go ahead and 5 more seconds. 4, 3, 2, 1. End it, Amy.
That is almost an exact tie for therapy and the MDS nurse. Interesting.
It is. That is very interesting. And we certainly have opinions on that. Lots of opinions on where we're collecting, who's collecting that information.
All right, so we are going to start by looking at the changes that are coming to Section GG. So there are a couple of key changes. There were some Section G items that were moved over to Section GG. We've got some new coding instructions, new coding tips. So we're going to kind of dig through each of those here. All right, so did Section G disappear? Yes and no. We had quite a few items migrate from Section G to Section GG. So technically not all of those G items are disappearing. They just, got moved around a little. Section GG will now, well, in October, be the sole section to capture and measure the residents' functional abilities. So we're going to take a look at what questions, kind of just put on their walking shoes and walked right over to Section GG. So first is range of motion. This item moved from Section G 0400 to GG 0115. The scale used to code this item should already be familiar to you. Really, we're looking at the limitations in range of motion and upper and lower extremities, those that interfere with the residents' activities of daily living or would place them at risk of injury in the last 7 days. So really not much of a change other than just moving from G to GG. Another item that moved from G to GG, I'm going to get really tired of saying G and GP over and over, is mobility devices. So this will now be item GG 0120, of course, beginning in October. This also should be familiar to you. We're looking for, any of those devices listed there. So cane, crutch, walker, wheelchair, or limb prosthesis that were used in the last 7 days. This again is the same coding instructions, or has the same coding instructions, and the same examples are listed in the new draft RII manual as well. All right, personal hygiene is another one of those items that moved over. This item was added to the self-care section, but there is one notable difference that I want to point out in the description of this item. So when this item was in Section G, as it currently is right now, it included brushing teeth, but now that it's moving into Section GG in October, it does not include oral hygiene. That's a separate question on its own. So for this particular item, beginning in October, we're only going to be looking at combing hair, shaving, applying makeup, washing and drying the face and hands. That will make up personal hygiene. All right, so bathing. Bathing also moved over. In the current item set, bathing in Section G includes both the act of taking a bath or shower and how the resident transfers in and out of the shower. In the new item set beginning in October, these are split into two separate items. So we'll have GG 0130E, where we'll code the resident's usual performance in the act of showering or bathing, excluding the transfer into and out of the tub or shower. Then we'll have item GG 0170FF, which is simply the tub and shower transfer. So the ability to get in and out of the tub or a shower. So to put it very simply, Section G item, that one Section G item is now broken into two in Section GG. All right, Section GG coding has not changed. So we are the REI manual is not changing the instructions or the coding options for Section GG. Those options will stay the same. However, the confusion has been, and kind of still is, that numerical scale is inversed when we're looking at Section G. So in Section G, those higher numbers indicated more dependence and the lower numbers indicated more independence. So of course, we had to make it super confusing. So just keep that in mind. My recommendation is to always double check the numbers when you're coding the MDS. I think if we've gotten in a habit of just dropping those numbers in there, really pay attention to what numbers you're entering into the MDS and make sure that they match up with that functional ability that you're wanting to code. All right, we are going to look at collecting, assessing, and coding section GG. This is the fun part. So the $1 million question, what does the word usual mean? So the REI doesn't really do a stellar job in defining the word usual for us. They basically say it's not the best, but it's not the worst. I mean, if you ask me what my usual morning routine is, I automatically think of what I've been doing every morning for several months or years, not just during the span of 3 days. But alas, we have to code these items to the best of our ability. And that means gathering as much information from as many sources as we can in order to make the most appropriate determination. So I was doing a little bit of research on the word usual. You know, we always think, I think I know what this word means. So I'm like, let me do some digging around. I found something that kind of stuck with me, and it said the word usual stresses the absence of strangeness or unexpectedness. And I kind of like that. I think it will certainly be something to keep in mind when we're determining usual performance, especially on those over assessments for our long-term patients.
I like that. You know, I've wondered a bunch of times, whose junior high teacher would allow them to use the word you're defining in the sentence of the definition? Usual performance means usual performance.
Right.
It's really difficult. And this is going to continue to plague some of our facilities, because one of the things that we struggle with is the amount of information that we collect. Do we have enough information to determine what the usual performance is? And that could be because we didn't trigger the assessments in our EMR. It could be that we haven't set up to collect it. It could be we're not capturing it as often as it's set up to be collected. We're late on our documentation, lots of things, but this is a growing concern as it impacts more and more of our practice, both clinically, so caregiver to caregiver communication, as well as financial, and setting the right baselines for our residents.
Yeah, so let's chat about where we're going to get all of this information. So many sources, just to put it plain and simple. There's a lot of different sources that we can gather all this data from. Like I mentioned on the last slide, you know, we're only looking at 3 days worth, so we need to get as much as we can during those 3 days. So first, we can observe the patient. We do this all the time. We're constantly observing things around us, our patients, and we probably don't even really notice it. So make a mental note, or better yet, a progress note, and you know, document what you observed the patient doing. What were they able to safely accomplish, you know, from a functional standpoint? Then, of course, we can ask the patient, interview them, have those conversations. You know, we're normally going in and checking on these folks within the first couple of days of their stay, and certainly when they're getting ready to go home on the last couple of days of their stay. So just ask them, you know, what do you feel like you're able to accomplish safely? Are you needing assistance from, you know, the helpers with daily tasks, and how much assistance are you needing? And then next, of course, review the documentation and also interview the staff and the family. There are so many places to get the data, and it's crucial to gather as much as we can so we can make that coding decision, you know, the most appropriate and the most accurate one.
I like that. You know, when you think about who's collecting this information, who we interview, it really should be everybody involved in the resident's care. And I think it's that lack of information. And when we think about setting up our schedules, some states and some facilities, they have 12-hour shifts, and we trigger that documentation once per shift.
Mm-hmm.
Well, then we don't have much information. And one thing I love to see are the clinicians, as well as everybody else on the IDT, out with the residents, because think about the information you can collect in 5 minutes when you're sitting with a resident and you're watching how they do things. There's a lot of information there. Does that information get to the medical records so that it's usable and part of the record? Because at some point we have to justify how we've coded this.
That's the power of that observation and IDT note. It's huge.
Nurses, therapists, even administrators, social workers can tell you a lot about the residents and what they expect them to be able to do and have seen them do by just sitting there and spending a little time with them.
Yeah. So now that we know where to get all of this information, want to kind of define what a qualified clinician is. So we get this question pretty frequently. So the REI states that CMS anticipates that an interdisciplinary team, qualified clinicians are involved in the assessing process during, or assessing that resident during the assessment period. A qualified clinician is a healthcare professional who practices within their scope and is consistent with federal, state, and local laws and regulations. So the important thing to remember here is that when we're talking about assessing, kind of talking about we're talking about coding, and I like to think of it as a two-step process. So step one, gather all the data from all your sources. Then step two is where the IDT, made up of those qualified clinicians, collaborates on that usual performance determination and makes the coding decision for the MDS. So kind of two steps. What we talked about previously is getting all the data from all the sources, then those qualified clinicians and that IDT get together and make that coding decision.
Yeah, there's been a couple of things we've done as an industry, kind of for survival and kind of for sanity, where a lot of states have continued to use Section G very actively and for Medicaid case mix, and where Section G has continued to be part of the MDS for, you know, quality measures and some of those other items. We haven't asked our aides and a lot of other people to collect that information because they're already collecting Section G information. So it concerns me that we're going to be able to pivot and transition this task from just the nurses, just the therapists, just those people who are really those qualified clinicians and their collections to the people on the floor, the CNAs, those who spend most time with our residents. I think that's our biggest hurdle. And I think that's where we really have to figure out how we change our process, our system, and the expectation as we move closer to October 1st, because we don't just flip a switch on October 1st and everybody knows what to do and does it differently and does it well.
That would be nice.
It would be really nice. Just, yeah, flip that switch.
All right, so let's talk about how we define a helper. So the RAI refers to a helper or helpers over 1,000 times. I did a word search in the RAI manual. Helper over 1,000 times. And the RAI tells us or gives us a definition that states, for the purposes of completing Section GG, a helper is defined as facility staff who are direct employees and facility contracted employees like agency or contracted rehab staff, etc. The term helper does not include individuals hired, whether they're compensated or not, by individuals outside of the facility's management and administration. So we're looking at hospice staff, nursing students, or CNA students. So when we're scoring these GG items, we're only to be considering assistance provided by facility staff. All right, so we're going to look at a couple of coding instruction updates here. You know, while the coding scale isn't changing, we did get some clarification in coding instructions for a few of the coding options. So when coding 01 dependent, the RAI clarifies two different scenarios and states that we are to code 01 dependent if two helpers are required. Did I say dependent? Yeah, dependent, sorry. If two helpers are required for the safe completion of an activity, even if that second helper provides supervision, standby assist only, and does not end up needing to provide hands-on assistance. So you've got somebody there to help out. If they're, you know, supervising and they're standing by, if they end up not needing to actually physically help with hands-on assistance, we still code dependent. The manual also instructs us to code 01 dependent if a resident requires the assistance of two helpers to complete an activity. One to provide support to the resident, a second to manage any necessary equipment to allow the activity to be completed. So you need somebody to grab you an assistive device, or whatever it may be. If there are two people in the room to complete that activity, it's to be coded as dependent. So that's some nice guidance here. I think that will help kind of take some of the guesswork out of, is it actually two-person assist or not?
And I like it. I like the way they talk about safe completion. And here's I've, for many, many years, as we've taught Section G and now Section GG, using that word safe, to me, always makes sense. And it's not stressed enough. And when we're talking about coding and saying there were two people there for that resident for assistance, even if one is standby assist, and people would push back and say, but they really didn't do anything. Here's my view on it. And this is supported now by the REI manual. You code it as per what really happened. There were two people there, so you code it that way. And clinically, if they didn't require that level of assistance, and next time you have one person rather than two, then you code it that way. And so you're not bending any rules, you're not twisting anything. You really are coding what it required to safely complete that task. And now, like I said, it's validated by the REI. So I'm really excited about this one.
I'm excited about this one. So lots of questions. I don't want to say controversy, but there were a lot of questions surrounding this little phrase when Section GG rolled out. So prior to the benefit of services, and it's been clarified, but it's also been changed a little bit. So the REI clarified this to mean prior to the provision of any care by facility staff that would result in more independent coding. So there's a change in that verbiage under the steps for the assessment. The current REI states, just to kind of give you a look at the difference here. So the current REI says the admission functional assessment, when possible, should be conducted prior to the resident benefiting from treatment interventions. The REI manual going into effect October 1 says for residents in a Medicare Part A stay, the admission functional assessment, when possible, should be conducted prior to the benefit of services. So there's a couple little changes there. They kind of took out the treatment interventions, replaced it with benefit of, any care, provision of any care by facility staff.
That's a huge change. It really is. And as we're working with nurses and therapists, the question is, how did that resident perform that specific activity without any cueing, prompting, repositioning by the caregiver and helper? And that's how you code it. Not once you gave them the cues, once you provided adaptive equipment and showed them how to use it, those type of things, you reposition them. It really is important. And it's important to get that baseline, because this is the starting point for your outcomes. And we'll talk about outcomes in a little while, but you want those outcomes. And that's part of the skill that you're providing, is that accurate assessment and baseline. And then what did your treatment, what did your care enable the resident to do?
Yeah, so we're going to look at a couple coding tips. I don't know about you, Mark, but when I go, digging around in the REI manual, I'm looking for an answer or looking for some guidance, I always go to the coding tips first. I think my eyes gravitate there because they're bulleted, they're concise. I always go there first. And they added quite a few really good ones for Section GG. So in regards to assistive devices, CMS doesn't give us an exhaustive list of what can be used when we're coding self-care and mobility. The REI tells us that our assessments may include any device or equipment that the resident uses to allow them to, again, to speak to what you said, safely complete the activity as independently as possible. However, we're not to code those self-care and mobility activities that are carried out while using a device that's pretty much only used in the therapy gym. So like parallel bars, overhead tracks, things like that. We're not going to really consider those when coding. Anything solely used in the therapy gym is really off limits.
Which makes sense. Those are training apparatuses. Those are things they're not going to use in the hall.
Right. Yep.
In their rooms.
Another coding tip to keep in mind when we're looking at Section GG, those residents with cognitive impairment. So, given the nature of their limitations or impairments, they're likely going to need more assistance, whether that be physical or verbal. So the REI tells us to code based on their need for, once again, assistance to perform the activity safely.
I like that. I could use that a million times a day. Safely. Did they do it safely? Not by, the hand of providence. Did they do it without hurting themselves? It really is. Did they do it safely?
So we also got a new coding tip for rolling left and right. And it tells us that if the resident does not sleep in a bed, clinicians should assess bed mobility activities using the alternative furniture. So something like a recliner, I feel like this is not uncommon to have patients who sleep in recliners. Now, my next follow-up to that is if they have COPD. You need to be asking them if they're part of a lie flat. They don't want to lie flat.
They don't. That's why they're in a recliner. I did home health in my early years as a clinician, and I can't tell you how many people had lived in their recliner for years. And those same people were being admitted to nursing homes, and they were taking their chairs with them. So I know this happens, and having worked in SNFs, watched this happen over years. So this is about time.
Yeah. I mean, recliners are comfy in this thing.
Yes, they are.
All right, so some more coding tips were added to help clarify the sit to stand item, which includes the resident coming to a standing position from any sitting surface. I think this was a big one. Actually, there were a couple of them. So next, to clarify sit to stand, if a full body mechanical lift is used to assist in transferring a resident from a chair bed to chair transfer, we're instructed to code that item as activity not attempted. They're not really going from sitting to standing. And then finally, if the only help that the resident requires to complete the sit to stand activity is for the helper to retrieve that assistive device or any adaptive equipment like a walker or AFO, whatever it is, we are to code that item as setup or cleanup assistance. That'd be a 05.
Makes sense.
All right, so in addition to the coding tips, which I already said, of course, are my favorite, there are a ton of really fantastic examples. I can't tell you how many times I've had, some sort of scenario and go to the RAI manual and I find an example that is really close to, if not exactly the same scenario that I'm looking for. So look at those coding tips, look at the examples. Sometimes it's very helpful just to know the intent behind what they're asking us. What is the intent or the item rationale for the MDS items that we're coding? I think it kind of puts some context into, what the day-to-day job is for an MDS coordinator. So
for sure. Like I said, I think we're a great resource, but the REI manual is the source. And whether you're taking those items one at a time and going through it, week by week by week, you still need to go to that source. There are great examples. There are great coding tips, and the information's there for you. Okay, we're going to change gears just a little bit. We have a new discharge function score that's coming at us pretty quickly. Unfortunately, there's going to be an information collection period, but we know that this new measure is going to impact both the SNF QRP and value-based purchase program, which makes me nervous. That feels like double jeopardy. It's like, oh, come on. You can hit us once with this, not twice. Well, quite frankly, CMS can do whatever they want as long as it falls within the rules that they've been legislated or have been legislated for them. So we have this discharge function score for all the SNFs. And like I said, it's going to include both those programs. So you need to be very focused on this. It has to be one of your top priorities. And the consequences could be far-reaching if you don't pay attention to this. So we know that data collection is slated to start 10/1 of 23. I don't know if that information is going to be used for anything consequential, but we know at least we're going to have to start reporting, or they're going to collect that. We don't have to report it. It's going to be automatically collected from our claims off the MDS. Be conscientious of that. You want to follow your results, because the performance year, and that's usually the standard you're going to be judged on, starts 10/1 of 24. So you have 1 year to get this right. After that, there probably will be consequences tied to this. While it's not tied to reimbursement yet, you can guarantee it will be.
It will be.
They've been talking about pay for performance for years. They've tried all these models. They've tried all these things. And with value-based purchase, we've been judged pretty much on one thing, rehospitalization. Well, they have up to 9 other items they can add. This looks like it's going to be one of them, and it makes sense. In the SNF QRP, same thing. It's been, are we completing a certain number of items on the MDS? And it's really a completion task right now. It's going to change. We're being told that, and this is one of the ways it is changing. So we know that this information is generally followed by consequences to our reimbursement. We know that the performance year is followed by a payment year, and that's usually a 2-year gap between those two items. And here's the problem, is the consequences aren't immediate. So a lot of times people will kind of defer these programs, because we have so much on our plates, they'll defer it to later, but then you have to live with those consequences. So don't defer this. There is a someday when it comes to when this information will impact you. So it looks like if they're collecting the information, your first data collection, or excuse me, your performance year is dated to start 10/1/24. The payment year will probably be 2 years later, 10/1/26, but it will come. One of the things I like about this, and when you're looking at the item set list that they're going to be collecting, it's eating, it's oral hygiene, toileting hygiene, rolling left and right, lying to sitting, sit to stand, chair or bed to chair transfer, toilet transfer, and then the walking 10 feet, walking 50 feet with 2 turns, and wheeling 50 feet with 2 turns. Well, this is very familiar, right? Very familiar. So we're looking at most of the items that are used to calculate Section GG scores for nursing and therapy PDPM scores and case mix groups. So at least they're keeping it the same. They're telling you, we're going to score these things for payment for PDPM. And now we're going to score the outcome of these items as well, with a few additions, but very few additions. So I like the fact that if we learn the calculations for Section GG for nursing and therapy, PT and OT, we also know the discharge outcome score for SNF QRP and value-based purchase. So my advice, learn these items, focus on these items, make sure your baseline scores and your final assessment scores are accurate. So when we talk about scoring these things and where the measure is taken from, it's pretty simple. It's the number of provider stays where the observed discharge score is greater than or equal to the expected discharge score, divided by the total number of provider stays. Then you multiply it by 100 to get your percentage. So how many times did it happen? Did you meet or exceed your expected discharge score versus the total number of stays that qualify? Quite frankly, it's a fair measure, in my opinion. They're telling you what it is. They're telling you the items they're going to collect it off. And it comes to us as clinicians and caregivers to make sure that the information is being entered accurately into our records. Measures risk adjusted means they adjust it for score, age, and resident characteristics. Quite frankly, the math gets complicated on those things, so I would not concern myself with that too much. I would be concerned on my baseline score and the goal that I'm setting. It's automatically completed for what they're calling complete stays, and we'll talk about that in a second. And then again, we're moving from simply recording information to the outcome of our care. When we look at the exclusions, they say residents with incomplete stays, which include death in facility, unplanned discharges, and AMA discharges. Those aren't going to be included. One of the conversations I've been involved with many times in my career is, should we count this as an AMA discharge? Because there are other consequences to that. And there's that compassionate side of us that we don't want to code it as an AMA discharge. Here's where we're going to have to be pretty objective and say, if it really is an AMA discharge, I probably have to code it as an AMA discharge, because there are consequences now to the providers if we don't do that. Then certain medical conditions, coma, persistent vegetative state, complete tetraplegia, locked-in state, severe anoxic brain injury, cerebral edema, compression of brain, those are excluded. Residents younger than 18 years. And those that are discharged to hospice or on a hospice stay while a resident in a skilled nursing facility. And then residents that did not receive physical or occupational therapy services at the time of admission. Now sometimes people might be thinking, hey, we're not going to be judged on this if we don't have PT or OT on our admission MDS. Please keep in mind there are other consequences. One is outcomes. You're not going to get the best outcomes if there's a delay there. Two, it's our obligation to provide all the right services at the right time. So we want to do that. And three, if you take too many people out of your measure, it's going to be difficult to positively compare to your competitors, because the lower your number, the more volatile your quality measures will be. So do the right thing for your residents. So when we're looking at this, we're really looking at those complete and accurate assessments. Set the proper baseline. It's that prior to the effects of the care that we're providing. We want to make sure that we're looking at those patients when they walk in our door, what can they do and what can they not do safely. The second thing is set realistic goals. And sometimes, especially in therapy, you'll see therapists, hey, I'm setting my long-term goals and I was taught in school to set them for 6 months. Nope. Set those goals for what you're going to accomplish within that setting, within a reasonable amount of time. Because if you don't, there will be consequences. Again, plan timely services, including PT and OT. Again, go do the right thing for the resident. Then ensure that any relevant exclusion conditions are properly coded on the MDS. And that's one of the first things you want to do is while I don't talk a lot about some of the covariates, exclusions, very important. That is something we control. That's something that we code. Make sure your coding and your diagnoses are correct. And the last thing is to provide an evidence-based effective service, whether it's therapy or nursing. What's the gold standard? Are we meeting that gold standard? And one of the things I hate hearing, and I know it's with the best intent, but a lot of times we'll talk about best practices. What's the best practice for this? What's the best practice for that? And when I go see the best practice, I'm usually scratching my old bald head and saying, shouldn't that be the standard of care? That's not a best practice. That should be our standard. That's what we should do. So we've got to watch that and say, we should be doing the best thing for our residents. We should know what the most effective interventions are. That's where we live. That's what we do.
All right, let's talk about some strategies for improving our Section GG collection and scoring. This is one of Mark's favorite sayings. Who does what by when? I mean, I feel like everybody performs better when you have a clear expectation that's set. So let's talk a little bit more about that. So first we have the who, right? We need, IDT members who are trained and held accountable for certain data elements or pieces of the process. While yes, of course, we know the NAC codes the MDS, but it can't be a one-person show. So for example, this is kind of an example of what this might look like. A NAC sets the ARD and opens or fires off those Section GG assessments in the EMR. Charge nurse or other nursing designee assesses the GG items during that assessment window, queries nursing aid staff about residents' performance, and enters that documentation into the medical record. Therapy staff include GG specific items in their documentation, and social services or other staff members also observe and document the resident's functional status. This, of course, could look much different for your facility and your team, but the point here is that each player has an expectation set. They know what tasks they are to complete, and by when, of course, right?
Absolutely, by when. It's a big one for us.
All right, so next is the what. So, what steps can we take to ensure a true interdisciplinary process? So train your team on the intent of Section GG. the items that are involved, and the coding scale that's used. Then retrain and follow up and retrain some more. Observe your facility's process. Is documentation occurring and is it correct? Again, rethink those old systems and ways of doing things. Or like you mentioned earlier, Mark, our staff only documenting resident performance once a shift when we know that bed mobility and toileting and transfers are happening multiple times throughout the day. Is that enough? Is that enough documentation? Commend those staff that are putting forth that great effort and consistently recording patients' functions accurately. Also, I know this might make some people upset, but
After that poll, it's going to.
avoid auto-populating the therapy documentation directly into the MDS. Remember, we have to consider all the sources. And if we're auto-populating, probably just leaving it there and letting it transmit right on the CMS. So just reconsider that practice, which I know is a pretty common.
Absolutely. And therapists are trying to get the best response out of their residents, not the lowest, not the usual, the best response. So rethink that approach.
All right, so by when do we need this information? What is that deadline? So first, know the collection windows. For admissions in 5 days, it's the first 3 days of the stay. For OBRA assessments, discharges, and IPAs, it's that ARD date and the 2 days prior. And like we mentioned earlier, prior to the benefit of services when possible. And then finally, take into consideration the time of day that those assessments are completed. And when those levels are documented. We know functional status can vary quite a bit throughout a 24-hour period. So just keep that in mind.
Okay, we're going to shift a little bit again. We're going to talk about the OSA, the optional state assessments in Section GG, or excuse me, Section G. I'm even confusing myself. Section G, not GG. Now, states are dragging their feet a bit on a few things, but we're going to have poll question number 2 real quickly.
All right, my state is using the OSA for Medicaid residents on October 1, 2023. So if you know the answer to this, and you've been keeping up with your state's practices, let us know, yes or no, or you don't know.
That's right.
States do make it a little bit difficult to find information. So we have to go digging, really digging, and phone calling and emailing.
Yeah, for sake of time, 5, 4, 3, 2, 1, stop. It's interesting, almost the same number of yeses and nos, actually the exact same number. And a big, I don't know. Well, here's the truth of the matter. Some states don't know.
Right.
So we're still waiting on some of the states to let us know. So let's keep going. So getting back to OSA. One of the good things is this is such familiar information, the Section G information that we use forever for our coding for rugs, that whole bed, eating, toilet, transfer, that's what it is. The difficult piece is going to be trying to collect this while we're trying to transition to Section GG. And that's tough because we have to have somebody collecting both these things. Now, it's your decision on who you want to have collect this information. But for your Medicaid case mix, if you're using the OSA, you need to continue to collect this information, and your states will provide you more guidance on where you'll be documenting this and when. So, but it's familiar information. You guys, I'm sure, already get this, because if you already need it, you're already doing it. One of the other things that we provided, and this will be available to you in the link, is just a crosswalk, therapy functional levels, Section G, Section GG, and it's a useful tool. And we won't walk through this. You certainly can take time to look through it yourselves. And I think it's a great tool because we don't speak the same language, and CMS is clouded the water by inverting scales and using different terminology in those measures. And then therapists are trained separately and have their own terminology. So one of the things that we need to look at and we need to be very focused on is, what do we do? We've got all this information. What do we do? We can start with a lot of really big items, but one of the things that really strikes me as a leader, as somebody that's run a therapy company, as somebody that's been in leadership in the skilled nursing facility industry for a long time in operations, is your meeting or is your team coming prepared to their meetings? Do they know what to do? It's that who does what by when? Are they coming on time? Are they prepared? Well, as leaders, you influence that. You set the expectations. Does everybody leave with a who does what by when list? Things I need to follow up on. And generally those are time sensitive. So it's before the assessment reference date. It might even be by your stand down meeting in the afternoon. They're time sensitive elements. And there's a consequence to not having very strict processes in place to collect that information correctly and timely. And then are you confident in your results? So you're getting results, people are checking the boxes, but is it the right information? The other thing is, how are you educating your people? We're all so busy. And one of the things that I really push our nurse, our clinical reimbursement specialists on who work with our MDS nurses is, how are you training people? Because they're really busy. You know, they're not sitting down for 3, 4, 5-hour seminars. They really need to be taught as they're working with the residents. They need 10, 15 minutes of training and then follow up. But how and what are you training? The other thing is providing resources, which includes time. And we're allocating resources. So we are bringing people in to train, or we are doing a train the trainer. We have a process in place to make sure people get the information they need, and they get it timely, and they get it in time that they can apply it and practice it before there are consequences. So one of the things that I'm very adamant about is care always comes first. We don't make decisions based on driving finances in this industry, and the federal government's telling us we should not do that. We should provide the care. We should carefully document that care, and then our documentation is going to be translated into proper coding. That's how we get reimbursed. Care always comes first, even when we're contemplating our financial processes and the needs of the business. The care comes first, and I encourage you to always put that or make that a priority in your practice. So we are about out of time. This has gone by really quickly. This hour has. Really appreciate you joining us. We have some references here. And obviously we provide MDS oversight services. We're happy to do that. So I'm going to be that good corporate partner here and let you know that we have quite a few excellent MDS oversight services. We also do a lot of other things in QRM, the in-house rehab management, multi-claim contractor audits, branding, marketing, even some recruiting, but great resources. We've got our contact information. Megan and I are always happy to hear from you. And I believe we're out of time, so we won't be answering any questions live today. But if you will send those questions to the Q&A box, we are happy to respond to those, and we will put together a Q&A document, and we'll send that out as soon as we can, as soon as we collect all those questions. So with that, thank you, Megan, for spending time with me today, doing this. This is always fun.
Always is.
And Amy, we'll turn it back over to you.
Thank you both. Wonderful presentation, and we're getting great feedback on the chat. So like Mark said, we will prep that Q&A document for everyone, and the webinar recording will be on the QRM website on our resource page within the next 24 hours. So if you missed anything or you would like to share it, we would love that very much. So once again, thank you everyone for joining us today, and we hope to see you in our future webinars. Take care. Bye-bye.
Bye.